Leukemia is the medical term for blood cancer. The common symptoms for leukemia are often non-specific to begin with. They can present with fever, which is not responding to, like not behaving like infections. They can come with anemia and bleeding. And this usually has a low platelet count in the blood counts. They can come with bone pains. So bone pains is the one of the major manifestations of leukemia. They can come present with weight loss. They can present with appearance of new nodes. These are called lymph nodes, which are routinely not palpable in adults. In children, they are usually small to feel. They can come with these enlarged lymph nodes. So these are often the common manifestations of leukemia. Many times we do not identify any major risk factor in a patient who gets diagnosed with leukemia, but sometimes if they were treated prior for a cancer, so prior cancer therapy can be a risk factor for leukemia. Some genetic syndromes are known to have leukemias, including Down syndrome, Fanconi anemia. They can have leukemia as one of the manifestations of the disease. They may be more prone for leukemia compared to the general population. Smoking and exposure to benzene in the smoke, and working in like exposure to radiation on a long-term basis to a toxic level, all these can predispose a person to leukemia. So leukemia often are classified based on the rapidness with which they are going to present. So if there is a very short duration from the time it starts and the symptom onset, those leukemias are called acute leukemias. And if there is a relatively longer period of symptoms, like longer period for the symptoms to develop latency, then they are called as chronic leukemias. So definitely, when acute leukemias are often they are very responsive to chemotherapy. The faster the disease grows, the higher its response to therapy, and there is a possibility of cure with chemotherapy, especially in children. Whereas chronic leukemias are often controlled with drugs. They can also be cured with some therapies, but often are aimed at the therapy is aimed at disease control. One of the easily available tests to detect or which gives us a clue that the patient may harbor leukemia. One of the earliest thing that happens is changes in the blood counts. So we have red blood cells producing, which has hemoglobin, white blood cells and platelets, which are the major component of the blood. And these parameters are easily checked by a test called complete blood count. So most of the centers can do, laboratories and hospitals can do a test called complete blood count, and the changes in the blood counts, the aberrancies, can be easily picked up in this blood test, which will cost around 200 to 400 rupees. Two forms of acute leukemia, the two major types of acute leukemia are acute lymphoblastic leukemia and acute myeloid leukemia. So if we see these two diseases are often treated by chemotherapy. Their intensive chemotherapy is given for these diseases to bring into control, and later for ALL the therapy is for 3 years. So 6 months of intensive chemotherapy followed by 2.5 years of maintenance chemotherapy. Whereas for AML, acute myeloid leukemia, the treatment is primarily intensive, which is often followed preferably with a bone marrow transplantation. For diseases that have onset in children, ALL, children with acute lymphoblastic leukemia, now at least 80 to 90% of them in current world are treated only with chemotherapy. Whereas for disease like AML, acute myeloid leukemia, bone marrow transplantation is one of the major form of treatment. So when the disease gets controlled with chemotherapy, it is always better to consolidate with a bone marrow transplantation in the setting of acute myeloid leukemia. And similarly, when acute lymphoblastic leukemia, which is cured with chemotherapy in children, when it happens in the adult age group, again, at least 50% of them will benefit with the role of bone marrow transplantation. When we start chemotherapy for patients with leukemia, often we see that their health deteriorates in the initial 2 to 3 weeks because of exposure to chemotherapy. But within a period of 4 to 5 weeks, so usually we say by 35 days, their count starts normalizing. So that would have been their major presentation of their disease. That is, they would have come with either very high WBC counts or low WBC count, along with platelet low counts and low hemoglobin. This, when the bone marrow disease is eradicated by chemotherapy, their count starts improving. So this is followed by a check of their bone marrow, and if this bone marrow is in remission, that is, if their bone marrow cancer cells are less than 5%, the blast cells are less than 5%, along with the test, we do a test called minimal residual disease assessment. So by these two investigations, we will know whether the bone marrow has gone into control with the treatment. So even after achieving that within the first 1 month or 1.5 months of treatment, still the treatment is given for the specified period to ensure eradication of the disease. So we will know that the treatment is working by both the achievement of normal counts at the end of first month and also with the bone marrow test results. Actually, when a patient gets therapy for leukemia, they are in a catabolic state. That is, they often do not maintain weight which is normal for their age and their body habitus. So it is very important to ensure a good nutrition during this period. So a good nutrition during this period also needs to be a safe and healthy nutrition. So it is very important to eat cooked food during this period. It is very natural to undergo the stress of the disease, because often that is a life-threatening disease, and there is a patient undergo a fear of they feel that they may die because of the disease in a day or two. So fear of death, fear of not getting well, fear of going through the side effects of treatment. So all this normally makes a person feel susceptible to stress of the therapy and stress of the disease. So it is always good to get a psychologist involved in the treatment from the beginning. Even if we feel that we are not stressed out, it is always good to have a mental health assessment during this period and seek the support of a psychologist. Out of 100 patients, especially 100 children, this scenario will not happen in 90 of them. That is, 90 of them are going to do very well, 90 to 95. Around 5 to 10% of children with acute lymphoblastic leukemia, there is a possibility that they will not respond to first-line treatment. So that is not a good news, but still there are options available, especially in the current scenario. We have therapies like monoclonal antibodies against specific leukemia associated antigens, for which, so these new drugs and the evolving and like we are anticipating this therapy to be available soon in India, CAR T-cell therapy. All these are newer agents and newer therapies available when we think that the first line is not working for a patient. Many patients wish to go back to work for few reasons, like to maintain their like income during the period of treatment, and also to keep them away from the stress of the disease and its therapy. But during the intensive phase of treatment, it is better that we avoid crowded places to ensure relatively germ-free environment. So in this, and the therapy will also make us go through phases of fatigue, phase of like we may be hospitalized. So in the initial 6 months of intensive chemotherapy, children are advised not to attend school, and usually we do not, unless we work from home, we really do not go back to our workplace. But in the acute lymphoblastic leukemia treatment, when the patient enters the maintenance phase, at that time it is possible to go back to work and go back to school. So definitely there is something called genetics, cancer genetics. Not though it is acute leukemia for every patient, the behavior of every acute leukemia may not be the same. So acute leukemia for some patients will be extremely responsive to treatment, whereas for some patients they really do not respond to any of the drugs that are usually very effective. So in this scenario, it is there are ways to identify whether the patient's disease will be responsive or may be resistant to treatment using the cancer genetics. So these tests are now easily available. It is the genetics of the cancer cell which is assessed both for good chromosome translocations and for bad chromosome translocations. It will give us an idea to know whether the disease will what will be its response to treatment. Similarly, by a test called minimal residual disease assessment, though we identify patients who have higher disease load despite achieving a apparently good response in one of the tests called bone marrow assessment. So by by looking in the microscope, we will know that the disease has gone into control or not. But by using advanced tests, at least 40% of the patients who apparently have achieved remission may not be in a very deep disease remission state. So this can be identified early by this test called minimal residual disease, and we can intensify treatment for these patients. Previously, we used to identify them to have a relapse later, but now by these tests, we are able to identify them early and intervene early. So chemotherapy often are feared to be painful, but chemotherapy, most of the time chemotherapy that is delivered in these diseases, both in acute lymphoblastic leukemia and acute myeloid leukemia, or intravenous injections. Few are intramuscular injections and few are tablets. So most of the time patient will be given an injection of chemotherapy, and this injection is administered through venous cannula that is inserted in the hands or forearm. So this can sometimes, if the chemotherapy does not really, usually chemotherapy is not painful if it travels easily, flows easily into the veins. But in case if chemotherapy comes out of the vein, there are few drugs which are called irritant drugs or vesicant drugs. These drugs can cause bad ulcers and make the area painful. So to avoid this, most of the centers use central lines called peripherally inserted central catheters, or portacat, or which are also commonly called as chemo ports. These make efficient delivery of the drug into the blood system without causing any local reaction. So by ensuring these central venous access device usage, the delivery of chemotherapy has become even easier and it is not painful. So most of the time, we have an option of choosing a multi-specialty hospital, a single specialty hospital. So when we consider treatment of acute leukemia, either ALL or AML, it is preferable to choose a center which treats at least 50 such patients in a year, 50 to 100 patients in a year. And also they should have an in-house blood bank which makes access to blood transfusion easier and also helps safe access to blood products. And it is preferable in case of ALL and AML to prefer a center with a facility for bone marrow transplantation, because as we discussed in the previous few minutes, that often, especially in acute myeloid leukemia, there is a need for bone marrow transplantation. So patient need not transition into a new center for transplantation. Patients also prefer to continue their treatment in one center, considering all this, like availability of a blood bank, availability of a bone marrow transplant unit, and availability of a trained, dedicated oncology nurses. These are the things that patients should look for when they are choosing a center for treatment. I hope you found this video useful. Thank you.